problem. Let's see. Hello, everybody. The deadline for this important event has reached its date. So today we are inviting Professor Yoshi and Professor Madarati. The topic will be the last issue that will be was mentioned by Prof. Yoshi when he was in Baghdad. So we heard many feedbacks. Some are claiming this is very new topics, and this is maybe not present even in literature. So you want to hear exactly from Prof. Yoshi his opinion about the last topics he mentioned in Baghdad. But before that, let me introduce Professor Yoshi Tiraushi. Professor Yoshi Tiraushi obtained his DDS degree in 1993 and completed his residency in endodontics at Tokyo Medical and Dental University in 1995, where he also received his PhD degree from the Department of Endodontics. Dr. Tiraushi is an active researcher with interest in investigating aspects of retreatment and has published several articles in prestigious peer-reviewed journals, like Journals of Endodontics. In addition, Dr. Tiraushi authored in several chapters in textbooks, including the 11th editions and 12th edition of Pathway of the Pulp and Endodontics, and the 6th edition of Principle and Practice. Dr. Tiraushi developed the Tiraushi removal kit that is widely used for removal of fracture files as well as gutta percha. With such great clinical experience, in-depth research investigations, and excellent publications, Dr. Tiraushi has been remarkably lecturing nationally and internationally, and was exposed twice on national TV for modern endodontics. Let's welcome Professor Yoshi Tiraushi.
Thank you very much for your introduction.
You are most welcome. And the other well-known and great endodontist, Professor Ahmed Madarati. He's a professor and consultant in endodontics. He obtained his bachelor degree in 1996, following postgraduate diploma in endodontics and operative dentistry 2001, and a clinical master in endodontics 2003. Professor Madarati attained his PhD degree in endodontics from the University of Manchester, United Kingdom, 2010. His experience in endodontics is recognized by the Royal College of Edinburgh, United Kingdom. Professor Madarati was granted many awards. He was ranked as one of the top 5 best researchers in the health and medical science of the 2011 Scopes Young Researchers Award in the United Kingdom, and won the second best prize by Elsevier in association with the US-UK Fulbright Commission. Professor Madarati has over 50 publications in prestigious dental journals, and he is currently an associate editor of the European Endodontics Journal and an advisory board member of the Saudi Endodontics Journal. He is an official reviewer for several prestigious journals. Professor Madarati is an international keynote speaker, and he extensively supervises hands-on courses worldwide. Professor Madarati is the founder of Excellence Endodontics Group, which is currently considered one of the top group worldwide.
Hello, everyone. Welcome, my friend, Dr. Yoshi, and welcome, everyone. Thank you, Dr. Abu Baida.
Welcome. I want to just introduce our gold and platinum, gold and silver and bronze sponsor of this great event. We will take a tour within 2 minutes.
Quickly, please. Dr. Abu Baida, you need to share the screen. Share the screen, please. Share the screen. Okay. Share your screen.
Okay.
Yes.
Okay. Let me. Okay. Wait a second. Let me share the screen. Okay. Okay. I'm already sharing the screen, but let me share it again. Okay. Can you see the screen now? Do you see the screen, Professor?
No.
No, you are not sharing.
I'm not sharing. I'm sharing.
I can hear the sound, but I don't see the presentation.
Okay, let me share this window then. Let me share the window. Hold on a second. Let me share the window. Okay. Share screen. I guess, Professor Madrati, since you are the host, you are the only one can share the screen. Let me see if I can share it. Okay. Do you see the screen, Professor?
No.
Yes, I can. Yes. Okay.
Okay.
Add to system. Yes.
Yes,
Okay.
yes. I can see the screen now.
Okay.
Okay.
Let's see the video.
You can share now. Yes. Start the video. Dr. Abu Baida? Share your full screen is better, Dr. Abu Baida.
We also want to thank the gold sponsor of this great event, Mutransfer Dental Mirror.
Your screen is not shared completely. Make it full screen, please. Dr. Abu Baida, can you hear me?
Yes, Dr. Ahmed.
You are not sharing completely.
I cannot
We can
hear
skip
you.
the marketing and we can start the scientific component, please.
Speak with whom? Excuse me.
Skip the marketing part and let's start with the scientific session.
Okay, it will end within 30 seconds. That's all.
Okay. Because we can't see anything.
Okay.
Okay.
Okay. Okay, I would like to thank the silver sponsor of this event, Master Academy, and the bronze sponsor of this event, Global Academy. Okay, now let's get inside the side topics. Okay. Yes, Professor, do you hear me?
Yes, I can hear you.
All we hear you, Dr. Abu Baida. You can go on.
Okay. Okay. First question, Prof. Yoshi. Is the only alternating material you are using right now is the NTA?
That's correct. I don't use gutta percha anymore.
Why do you so?
Because first of all, you do not want to put something that does not bond to denting, because the goal of endodontic treatment is to seal the root canal, and you do not want to allow bacteria to go outside the root canal, which will cause epiglottal disease. So that's why I do not want to put anything that does not bond to denting in the root canal.
Okay. What do you think, Prof. Madrati?
Yes, I do agree with Dr. Yoshi regarding that one of the disadvantage of Cotebertia, as we all know, that Cotebertia by itself doesn't bond to dentinal walls. And to get complete seal or tight seal, we need a material that bond well to the dentinal walls and the canal walls. And that's why we use the sealer. So the main function of the sealer to provide that bond. But there is a part of what Dr. Yoshi mentioned, which is about why he doesn't use Cotebertia anymore. And I want him to elaborate more, please, that if you are not using Cotebertia anymore, so I guess that you are using, as far as I've heard, you are using MTA for all cases. Is that true, Dr. Yoshi?
Yes, that's correct. I stopped using gutta percha about 10 years ago. No, maybe almost 10 years ago. And
Okay.
so as I told you, the reason why I stopped using gutta percha is gutta percha does not bond to dentin. And even if you use sealers, gutta percha can be contaminated, and that would be, if it's contaminated, then you may have apical disease in the end. So that's why I do not want to use the gutta percha. There's no merit of using gutta percha in the root canal.
So you are using instead of it MTA, as far as I know.
Yes. I just put only MTA in the root canal.
And here, like, I have many concerns, and we need to clarify, which is, this is something like extraordinary, and I consider it as a revolution in endodontics, not to use gutta percha. So my question, or my first point is, then how are we gonna explain the long history of success rate using gutta percha? And we all know, and you know, that success rate, as some reports shows, up to 95%. So how are we going to explain this high success rate using gutta percha?
Yes, because the success rate, endodontic success rate, depends only on the coronal restorations. If it's good, then you have higher success rate. But if it's not good, you will have a lower success rate. It all depends on the coronal restoration, because gutta percha allows bacterial leakage into the periapical tissues.
Okay.
So it's only about the restoration rather than the filling material?
Exactly.
I may not agree with you, my friend, because one of the reports, when they compared between the lateral compaction and vertical compaction, and of course the cleaning and shaving method, this study, they found that cases that were flared and prepared with the ground down technique and vertical compaction, the success rate was significantly higher than those cases cleaned with a step back technique and lateral condensation. So the obturation technique at the end of the day makes difference using gutta percha.
Yes. Yeah, I know the studies. And if you look at the systematic review, and all the cases comes from the 2D radiographs. If you look at the 3D, the systematic review using CBCT, the success rate will be dropped to like 83% compared to the 92% from 2D radiograph.
Okay.
And what about
I'm sorry, you are missing the lesion in the cancerous bone, because the lesion in the cancerous bone is not clear on the 2D radiograph, and which is considered success.
Okay. So what about the retriability, the ability to be removed? Like, so I assume that what you're saying, what you're saying, like, if we are going to use MTA, that means we will have 100% success rate. Is that true? This is what the assumption.
Yes, actually, if you have a failure when you use MTA, it's almost impossible to remove MTA. But in that case, I always use. I always do the surgical approach. So it doesn't have to be removed.
Yeah, and according to what you found, or I assume that you did a lot of cases by this technique. And all our now colleagues who are attending this webinar, I think they are very keen to read an article claiming that using MTA material will lead to high success rate. And according to what you mentioned, that in case of failure, that means it's extra-radicular infection, not a reason from inside the root canal. Is my assumption true?
Yes, in that case, MTA does not work because when you have a failure,
Yes.
the reason why you have a failure is extraradicular infection, which cannot
Yes.
be removed unless you do the surgery.
Mm-hmm.
So
Okay.
that's true. But if you have biofilms, inside the root canal, gutta-percha cannot remove the biofilms, but MTA does.
Yes.
So why do you have to use a material that does not eliminate bacteria from the root canal? Because all the root canals can be contaminated with the gutta-percha, which is already contaminated from the beginning. And how do you expect the gutta-percha to eliminate bacteria inside the root canal? When you have biofilms, it's impossible to remove with gutta-percha.
Yes. So again, just not to miss this point.
Yes.
What you claiming is that those cases that fail after using MTA obturation, it means definitely that it's extraradicular infection, not intraradicular infection, right?
Yes.
Intracanal infection.
Is there any published work that confirmed this statement?
I don't think so.
That's what I and all other colleagues want to read at the end of the day.
Yes. So I don't see any literature, and because even if you put MTA inside the root canal for persistent periapical periodontitis, it's impossible if it's coming from the extraradicular infection. So all you have to do is to do the surgery to remove extraradicular infection.
Okay.
And
next
what
question.
about sealing the lateral canals? And we know that lateral canals, especially those large one with large diameter, if they are not cleaned and filled properly, they will cause lateral lesions. So
Exactly.
will MTA be able to seal those areas?
If there is no extraradicular infection, you can use MTA, and you can push MTA into the lateral canals or apical bifurcations in the small anatomical spaces, including aneurysms.
And for how deep, or what is the distance of the lateral canals that the MTA will be able to fill that space? The whole depth of the whole distance of lateral canals can be filled?
Yes, of course, because first of all, the particle size of MTA is smaller than the size of dentinal tubules. So why not into the lateral canal or apical bifurcations? And I have many cases where I put MTA in the lateral canals and apical bifurcations from the 3D studies.
And the MTA was able to fill those lateral canals?
Yes, definitely, yes.
So that means the consistency of the MTA is not the same that we use as a cement, when like the one that we use for perforation repair. Is that true?
Yes, but it's not good enough. You need to use ultrasonics or even sonics to push MTA into the small anatomical spaces. So you need actually vibration to put MTA into those areas.
Okay, so definitely we need something like a study to prove that long-term study. When we say like a long-term study, it's for more, that more than 4 or 5 years to prove that using MTA can be, or the MTA can be replaced completely the Cotebercia. This is one thing. And the other thing here now, what if I'm going to use the intracanal space for a restorative procedure later on?
Okay. In that case, first of all, you need to make a treatment plan before you touch the tooth, if you're
Okay.
planning placement of a post or something in the root canal, you
Yes.
need to leave the space for the post placement.
Yes, this is, but life is not easy like this, my friend. You know, like sometimes we do root canal treatment for a tooth that doesn't need any crown, just normal restoration, and maybe in 4 or 5 years, one part of the crown fractures, which means that we have to insert the post and a crown. So that means we need to use the intracanal space. And if it is already filled with MTA, so in such case, I cannot do anything. And the tooth is for extraction.
No. Because
Please correct me if I'm wrong. Yes.
yes. Because actually, I receive patients with MTA obturation sometimes to retreat the cases. But when I see MTA completely filled to the orifice, I use just ultrasonics to break down MTA fillings, because it's
So
not difficult.
Yes, I got your point. So that means you need to remove the MTA at the end of the day.
Yes, exactly. In that case.
Exactly. So my suggestion, why we don't have something in the middle? Like, you know, now the single cone technique, it relies on that we use Kotebercha cone, not because it is as a Kotebercha, rather than a safe side. If we need retreatment in the future, then we have that part of the canal that can be easily prepared for retreatment or for using it for intracanal post. So my suggestion here, or my point here, and I'm sure maybe you have you are thinking out of the box completely in a very excellent way. Why don't we take the advantage of Kotebercha regarding this point and the properties of the MTA, as you mentioned, and we can use both of them for root canal treatment? You got my point?
Yes, yes, I do. And actually, there are many studies. If you have MTA from the root end to the orifice, not just MTA plug in the apical 1/3, you have a higher success rate if you have MTA all the way down to the apical end.
Sorry, I missed that point. Can you say it again, please, Dr. Yoshi?
If you have MTA from the end of the root to the orifice, you have a higher success rate.
If it is completely MTA.
Yes.
But what
you
if
have a
I
higher
use?
Success rate. Sorry.
Yes. What if I can use the Kotebercha cone and the sealer MTA completely? And I'm sure that companies are working on that to get a sealer that the majority of its component and ingredients is MTA. So I think that will be more accepted from practical point of view, rather than just filling the MTA completely with the canal with the MTA cement. This is what
I see your point. Yes. I can agree with you, but I do not want to do that, because I do not expect the case to fail in future, because I want to be 100%.
Sure. Okay, we think he lost connection. Professor, you hear him?
He's still there. Maybe just
He lost connection.
I think so. No, he is still there. I can see. Yes.
Do you see my point?
I'm afraid that you need to say it again, because the connection was lost with you, my friend.
Oh, okay. So, yes, I can agree with you on that point, but still, I want to fill the root canal with MTA alone, from the top to the end, from the orifice to the root end, because just because the success rate is higher in that case. and because I'm not thinking about retreatment, because I want to be perfect in the initial root canal treatment.
Maybe for you, my friend, that you don't think about retreatment, but in real life, Indo, a lot of us think about retreatment. And that's why retreatment ability is one of the main criteria that Grossman considered 40 years ago. So that means we need to change those criteria. My last concern here.
Excuse me. Can I add something to your comment?
Yes, of course, my friend.
Yes.
Go on.
Okay. Actually, the success rate in 60s is the same as 2000, according to the systematic review, because what changed from 60s to 2000 was the rotary instrument, which actually facilitated the speed of root canal treatment. If you don't use the nickel titanium rotary instrument, maybe it takes 1 hour or 2 hours to finish the case. But if you use the rotary instrument, maybe you can finish the case in maybe 10 minutes or 20 minutes. But the success rate is still the same as that of 60s.
Okay. So to summarize this, what I believe that Dr. Yoshi approach, just because he is decreasing or reducing the possibility of retreatment. That's what has changed, right?
Yes, exactly.
Yes. So
that's why you need to change the materials that goes into the root canal, because the success rate is the same, has been the same for more than 50 years, actually.
Yes, I do agree with you at this point. So what about the severely curved canals? Like in severely curved canals, there are some canals are really very difficult, and very difficult even to negotiate and to instruments. So I can't imagine that such canals can be obturated with MTA. How to obturate a canal that I faced a lot of difficulty even using the best rotary system. How I'm going to obturate this canal with MTA?
That's a piece of cake, because I do that every day. And if you are able to instrument the root canal, then you can obturate the root canal with MTA, because what you need to obturate the root canal with MTA is an instrument one size or maybe two sizes smaller than the apical size. And you can just push it with the instrument that you selected, and you can rotate the file counterclockwise using an up and down motion.
Okay. And have you did any study, my friend, to see or to measure the porosity within the root canal or within the obturation in such cases? Because here I assume that you are claiming that it is easy, but I still believe it is difficult, not as obturation, rather than getting very tight filling material inside the canal. There is no any micro gaps that might be a place for bacteria. That's my concern here.
Okay, I know what you mean, and because in my office I take CBCT after MTA obturation, and to confirm the fillings to the apical 1/3 or the apical foramen, and every case I have I see the MTA fillings to the end of the root.
Yeah, but CBCT is not accurate in this regard, my friend. It shows you the extension and whether the canal is filled well in the macro level, but in the micro level, which is this is what we care about, the porosity. The CBCT will not show if there is any porosity within the filling. So I assume that we need such a study, and hopefully maybe in the near future.
Yeah, you can have voids in the MTA fillings, but it doesn't affect the success rate, because if you have MTA inside the root canal, that seals the space, and
Yes.
even if you have a void, it doesn't matter. It doesn't affect the success or the outcome of the endodontic treatment.
Yes, this is what we need really to have, just a kind of a clinical study in with the long term, or let's say 4 or 5 years, just to confirm this is what you claim. This, you used to do that, but all our colleagues now who are attending this webinar, I'm sure they will have this concern that we need at the end of the day a study, clinical study, or in vitro study that confirms this claim.
Exactly. So
Yes.
actually, I'm writing an article to compare the MTA fillings, like overfilling or flush filling or under fillings. Then, because I'm still writing the article, so I'm not done with the article yet. But
Yes, great.
all the cases with overfillings and flush fillings have a higher success rate compared to the cases with underfillings.
Okay.
It's very important if you have success cases or failure cases.
Okay, Professor, are you done, Professor Madarati, with the Professor
Yes,
Yoshi?
yes. I think we covered this topic in details.
Okay,
Thanks to
okay.
Dr. Yoshi.
Last question about Gatipirka. Do you think one day we will wake up and see that Gatipirka is out of the market and the future is purely for MTA?
Yes.
You get my question? You get my question?
Yes. Yeah. In future, I think Garapacha has a, I think, shorter life, but MTA is now getting into the market, and it will be dominant on the market very soon because of its advantages over
maybe we'll get MTA cones and MTA sealer, and that's it.
Yeah, all you need is just how you device to make it easier to fill the canal.
So one day we'll think that no system B, no obturating systems, no gata core, not all of these stuffs, right?
Yes. No more Garapachas.
This is not a good news for companies that making system Bs and obturating material, other than MTA. Okay, Professor. Now let's talk the most important and hot topics. Are you obturating wet canal?
Wet canal?
Completely in literatures. If you go back to literatures, you cannot find any literatures talk that you can obturate wet canal. You have to wait until get it dry.
Yes, because people are obturating the root canals with a Garapacha and the sealer. That's why the canal must be dry. But when it comes to MTA, it doesn't have to be completely dry. It can be wet because MTA is hydraulic, and it's impossible, almost impossible to dry the canal completely. So MTA is more favorable.
Okay, but the fluid that's come inside the canal will have bacteria.
Fluid?
And yes, the fluid. This is my affect the prognosis rate or success rate.
Because it's impossible to completely disinfect the root canal during instrumentation. So that's why MTA is better in terms of bactericidal activities.
Okay, Professor, you have studies will be published soon about obturating wet canals? We are waiting, and all the colleagues waiting for such a study.
Oh, you mean the comparison between wet canals and dry canals?
Yes.
Because all the canals are kind of wet, so I don't care if it's wet or dry. So I don't do any studies regarding the success rate when the canal is wet or when the canal is dry. Because I consider all the canals wet. So,
but there's a huge difference. Oozing canal.
I have a concern, my friend.
Yes.
When we say that wet canals, we need to differentiate what kind of liquid we have inside.
Sure.
Because I believe that also the difference between like having blood, for example, is completely different. That if you have pus, the consistency of pus will make that if we have a layer on the canal walls, that layer of pus, I don't think it will be filled completely with MTA.
Yes.
Like if you're having very,
you're right.
Yes, you got my point.
Yes, I got your point. And if you have too much blood or if you have too much pus, then I think you have to wait until it's gone. But if it's coming, keep coming, and then I may not be able to fill the root canal with MTA.
So you are feeling it when it is slightly wet, right?
Yes, at least if it's not wet with blood or pus, then if it's wet, then it's okay. But if I see lots of blood, lots of pus, then I just wait, or I will suction blood or pus coming from the apical tissues.
Okay.
And you obturate same visit.
Excuse me?
You will obturate in same visits. You will suck.
Yes. Because 80% of my cases are finished in one visit.
One visit. Okay.
So why not to wait till the pus stops completely?
Yes.
What is
Not
the point
completely.
here?
Okay. For example, if I wait for maybe 10 seconds and I don't see any pus coming from the periapical tissues, then it's time to obturate the root canal with MTA. But if it keeps coming, then maybe I will send the patient back home, and I will have the patient come back in a week.
What's
Okay,
your
so-
intracanal medicament? In
Yes.
such case?
So here you see
No,
Dr. Abu Baida.
nothing in the root canal.
Yes,
during the,
this is very important because I think some colleagues, they misunderstood what they understood, that if the pus is still coming slightly, you can obturate. But according to what you mentioned now, you try to dry the canal. If the canal is dry, then you can obturate. If it's still pus coming, even it's a little amount, you will dismiss the patient and ask the patient to come again, right?
yes, I always wait for 10 seconds. Then
Yes.
if I don't see any pus coming out, then I will obturate. I will go ahead and obturate the root canal. But if I wait for 10 seconds, if I still see blood or pus coming into the root canal from the apical tissues, then I may not want to obturate the root canal.
Okay, Prof. But if you see no pus or no blood is coming, but the canal is still wet.
Yes.
How
Then
to come
it's okay.
wet?
Slight
Excuse me?
wetness. Slight wetness. Do you obturate with a slight wetness?
Yes. In that case, yes.
Okay. So it is not important to get completely dry canal. Even if you see small wetness, few wetness, you can do obturation, right?
Yes. Because as I told you, MTA is hydraulic, so it doesn't matter if it's wet or dry.
Okay. Professor Ahmed, you have anything to?
No, just that's completely clarified. In a way, like almost we can say that Dr. Yoshi is obturate the canal when he can dry the canal for 10 seconds, which is logic.
No, I don't think he means that. I don't think. I think he is saying even you have slight wetness, you can obturate, not totally dry canal.
No, he is trying.
I want to say that if I don't see blood or pus coming into the root canal from the apical tissues, then I will go ahead and fill the root canal.
We have to differentiate pus or exudate.
Yes, pus, yes, or blood. But
No,
if I see something transparent, then
Yes.
I will go ahead and fill the root canal.
See, Prof. Madrati, he's still wet,
Yes.
he's still obturating the canal if it is wet, but not pus. He's talking about pus and blood, not exudate.
Yes, but after he dries the canals? Is that true, Dr. Yoshi? You dry the canal, you wait 10 seconds, you don't see anything coming out of the canal.
Yes.
So why this is what he is mentioning?
No, he's not saying that. He's not saying that. I'm sorry. He's saying a blood or pus, not exudate. Exudate means transparent fluid. He don't care about transparent fluid. He cares about blood and pus, right?
Yes, yes. Because if it's transparent, it's not blood. That means you have no inflammation in the periapical tissues. So,
Okay.
So it's okay.
Even if it is like it's filling the whole root canal.
Yes, yes. But like when you do the surgery, you have blood, and but you need to still do the retro fillings in conjunction with blood. You cannot completely dry the root canal.
I got your point. Here, Dr. Yushi is taking the advantage of that MTA by itself is hydraulic. The nature of the exudate, let's say, doesn't indicate that there is like the infection, let's say, it's not that severe. He is sure that the patient will not have a flare up, right, Dr. Yushi?
Yes, exactly.
So everything is indicating that the case will go okay. So here he's taking the advantage of MTA that it can be used in wet environment, which all we know that. So our concern that is, if you're going to obturate, are you going to provide good seal? Will the patient have a flare up after you fill the canal? So all indications, according to what Dr. Yushi is mentioning, that he is sure that patient will not have a flare up, and he is sure that the MTA will work in wet canal. So why not? This is his point of view, and I do agree with him to this extent. But the point is, now, to what extent we can differentiate or we can judge what is coming out of the canal, that it is really like transparent, or it's not that infection. This is a point. Am I right, my friend?
Yes, you are right.
Okay, then let me ask you this question. This question was by Professor Isam Za'atar concerning obturating wet canal. He is saying either your theory about using MTA in obturating weeping root canals, even with pus. You are not saying with pus, right?
Yes, he didn't say with pus.
Okay, so Professor Isam Za'atar, he is not obturating a wet canal if there's a pus. If there is transparent exudate, little bit, he will obturate. Otherwise, he will not obturate.
Exactly.
Okay.
Yes.
Okay. Let's move to the other question. You need slow setting MTA, right?
Yes, yes, I do.
Slow setting MTA. Okay. Why not you are using bioceramics or putty or even biodentine instead of MTA?
If it's a slow setting, I would use it, but bioceramics usually set in 10 or 15 minutes. So I do not want to use the MTA that will set in a shorter time, because I take a radiograph after obturating the root canals with MTA. If I'm underfilled, then I will go back and remove MTA and do it again. So that's why I want to use a slow setting MTA.
Okay, Professor, let's go to the hottest topic. What's your management for hypochlorite accidents?
Okay.
Yes.
I got the news, my friend. I got the news.
Okay.
Because this question was frequently asked me about, and
after you come to Baghdad.
Yes. And because I was trying to write an article about sodium hypochlorite accident in the pathways of the POP, but I was actually rejected from writing that part because it is not supported by studies. But when you see this accident from a clinical point of view, because I've had several cases regarding the sodium hypochlorite accident, and in that case, I actually, on purpose, I use hydrogen peroxide outside the root canal, and the first reaction from the patient was, "Oh my God, you're hurting me," and I have a big pain. Do something, please. Then I said, "Okay, please calm down. The pain will be gone in a few seconds. Just trust me." And after a few seconds, the pain is going away, and the patient is getting better, and there is no more post-operative pain.
How many cases you have?
Because the chemical reaction between sodium hypochlorite and hydrogen peroxide was you will get oxygen and sodium chlorine and also water. That's all you have. But if you have high oxygen in the periapical tissue, that will create emphysema. So that's why a patient will suffer from the big pain.
Okay, but no concern about emphysema. A patient will not attend hospital. He will not die.
No. But if you leave it alone, then you will have a serious accident, because if you have a sodium hypochlorite in the blood vessels or maybe in the muscular tissue,
muscles.
you will have a permanent damage. I mean, that's possible.
Okay, but Professor, we need a study to rely on. This is a serious measurement.
Exactly. But I have actually small study regarding that, but not clinical study, in vitro study. And like when you put sodium hypochlorite in your jacket or any clothing, you have bleaching on the clothing.
Yes.
But if you put sodium hypochlorite in the clothing, then you immediately put hydrogen peroxide on the same place as you put sodium hypochlorite. Then you have no bleaching on the clothing.
Okay.
Can I have some comments regarding this point, my friend? You already mentioned one of my questions, which is that your chapter in Pathway of the Pulp in the latest edition and the edition before, because you wrote that. So that statement need to be changed completely, because you already mentioned in that statement that the swelling is further exacerbated by the presence of agents such as hydrogen peroxide. So what a coincidence that you already mentioned that, and you say that you should not use it, and now you are using it. So since you mentioned you wanted to change, and the editor of Pathway rejected it, and I think that's logic. Yes. All of us now are waiting for a case report, not clinical study, case report about your protocol. Because the good news, if we go to the literature, there is no agreement on exact clinical management of this accident. This is a good point for Dr. Yoshi, because there is no agreement. Everyone dealing with the case according to what he believes. Some, for example, they are using just antibiotics and analgesics. Other, they are using steroids and analgesics. Even one case I've read that the patient was managed just by topical ointment. You can believe that? So there is no agreed protocol. And this is a good point for Dr. Yoshi. Like once he published one case report or two case reports, and I think we will be able to justify, as long as the regulations in each country allows such protocol. And here I'm going to ask Dr. Yoshi, what is the regulations in your country, my friend, are you allowed to do this and claim that you are doing this without any further questioning?
Oh,
Legal issues.
because if you can manage the situation like that, then you won't be arrested. It's not a crime to use hydrogen peroxide in the sodium hypochlorite accident. So as long as the patient is happy, we will not be arrested or prosecuted.
So here the question now, do you confirm that the reaction of body tissue to the injection of hydrogen peroxide is the same for all patients?
Yes, but because there is no study regarding this accident, and I can just, because I have I think 5 cases where I use hydrogen peroxide when I injected sodium hypochlorite into the periapical tissues, and when the patient was in a big pain, and all the cases were actually okay, no post-operative pain or any further accident developed later.
No swelling, nothing happened?
Nothing at all.
At all?
Yes.
And you didn't use any other drugs, like antibiotics or steroids or analgesics?
Nothing. But actually, 2 weeks ago, I had a emphysema because I was trying to remove the broken instrument from the periapical tissues. The broken instrument was between the cortical plate and the gingiva, but the patient was referred to me in that situation together with the referring doctor. And I told the patient, I think this case is better managed if I do the surgery. So let me just make an incision and take it out. And they said, no, because the patient is hemorrhagic and you cannot make an incision. And this has to be done in a hospital. So I had no choice. So I was trying to see the broken instrument outside the root canal. So I have to, blow air several times. That actually created emphysema. Yes, and after maybe 30 minutes, the patient was in a big pain, and actually the patient couldn't open her eyes because of the emphysema, and then I had no choice but to stop what I was doing and sent the patient to a hospital, and the patient stayed in the hospital for several days until the emphysema was gone.
Okay.
Now,
so the last we need. I'm going to ask Dr. Yoshi.
Yes.
Is your approach the same? Even like if you are dealing with sodium hypochlorite accident in lower second molar, which is very close to the nerve, or if it is upper molar and very close or interfere with the maxillary sinus, is the approach the same?
Yes, approach is the same because I don't want any serious accident, like a permanent damage to the nerves or the muscular tissues.
And what about the long term? No long term like side effects?
No, of course not, because you can just neutralize the sodium hypochlorite with hydrogen peroxide, but nothing further will happen later.
Yes, this is what we say in theory, but like when it comes to a human being, they will ask for, like, let's say an experiment on animals at least, to show that there is no any further effects on the long term by injecting hydrogen peroxide. So I think that we need such a study, my friend.
Exactly. Yes, we need such a study, like animal studies or maybe human being study. We need that study to confirm it's safe to use sodium to use hydrogen peroxide in the sodium hypochlorite accident.
So till then, for me, I will stick to what is mentioned in the literature, for me at least.
Okay. Maybe I will write a case report using hydrogen peroxide in the sodium hypochlorite accident.
Yes, that's great. That's
okay,
great.
so Professor Yoshi, can I say you are saying a declaration that dentists are safe to use hydrogen peroxide in case of sodium hypochlorite accident?
Yes, because I'm 100% sure that if you use hydrogen peroxide in the sodium hypochlorite accident, the patient will be better and there will be no more postoperative pain. But in a few seconds, the patient will suffer a big pain. That's
How do
what
you
I
deal with
expect
these
to happen.
seconds?
Yes,
How do you deal with these seconds?
Pardon me?
How do you deal with the patient in cases in these few seconds when he has severe pain? Are you just watching him, waiting for him?
Yes,
Leave him suffer?
that's inevitable. That's inevitable. But because you cannot avoid the big pain from the patient, and so you have to warn the patient. But I don't think you have lots of time before the situation gets worse. So I just immediately do it, and when the patient screams,
and then tell the patient.
Yes, exactly.
Okay. What I do intrapulpal anesthesia when I have accident. First line of treatment, first line management, I give intrapulpal anesthesia deep inside the root canal, just to relieve pain. What do you think?
I don't have that kind of experience, so. But usually, if you have a sodium hypochlorite in the bone housing, it's not a big issue. But if you have a sodium hypochlorite accident between the cortical plate and the gingiva, maybe the patient will develop a big pain after the treatment.
Okay, maybe last question, Professor.
Let's summarize this point, please, Dr. Abubaida, that according to what Dr. Yoshi mentioned, all the cases that he dealt with using this approach were safe. Our just concern is the ethical and the legal aspects. Our concern also is about the long-term effects of using hydrogen peroxide. And here we need definitely like animal studies and whether the patient, all the patient from different countries, from different races will react similarly to this approach. And Dr. Yoshi is confirming that it will be the same. And he is going to publish case reports about the cases he managed in this way.
Yes.
Okay. But one of my colleagues is saying that emphysema is a dangerous complication and can lead to cardiac arrest.
Yes. I'm aware of that.
Okay, maybe last question. What's your protocol or what's your management of over-extruded Gatepierke? How do you deal with it?
I use if it's outside the root canal, and I just use the expand shaper in the presence of chloroform. Yes.
And if there's some pieces still inside.
Yes. If you don't see the garapacha outside the root canal on the radiograph, I think it doesn't affect the post-operative pain or the outcome of endodontic treatment. So, because macrophage will take care of the remaining garapacha in the periapical tissues.
Okay. Do you allow the chloroform to pass through the apical foramen?
The apical, yes. I do that all the time because chloroform evaporate in a shorter time, depending on the amount of chloroform you use.
But it is a cytotoxic material, or it is caustic material. Is it safe to use it?
Yes, because
outside the apical, outside the root canal.
As far as I know, there's almost no reaction from the patient when I injected into the periapical tissues. Because I don't anesthetize the patient in the treatment because I would rather have my patient complain about the pain I am causing. So I don't anesthetize the patient. So in that situation, even if I inject it into the periapical tissue, then the patient will not complain about the pain.
Okay.
But
Last
the
question
concern here, my friend, you know, like when it comes to whether we are allowed to use any like any drug or any material, it's not about the only about the very soon reaction rather than the long term. Like for example,
Yes.
amalgam. Okay, now you know that in some countries it is banned because they realized that the mercury or the silver there it
Exactly.
has a long-term effect that might not appear maybe after 15 years.
Exactly.
So here again, what you're saying that okay, and nothing will have nothing happened maybe in 1 week, 2 week, 1 month, 2 months, 1 year, 2 years. But what about longer time? This is a big issue. I'm afraid that I cannot agree with you in this, my friend. It's okay that your patient is not is okay in the short term, but what about long term? Because now thousands of dentists are listening and attending to this webinar,
Right.
and we have the concern. What about the long term of using chloroform intentionally inside vital tissue, inside the bone?
Right. So first of all, chloroform will be decomposed in a shorter time, like depending on the amount you use. So if it's a small amount inside the root canal, like 1 mm, or I don't know, maybe at least less than 10 mm, then you will have no problem, I think. And first of all, the chloroform is not carcinogenic, and it's not proven to be carcinogenic in human. And so I think it's okay because it doesn't matter if you use it inside the root canal or in the periapical tissues. And
I'm afraid
because
yes, I'm afraid
98%
that
of my
I
cases.
still don't agree with you, my friend, on this.
Okay,
And
okay.
yes, for me, I will
Maybe
leave
you
the
need a
cotavertia to let
long-term
the
study.
body deal with it.
Yes.
If the reaction, if cotavertia, extruded cotavertia caused post-operative disease, then I believe that surgery is the approach of choice for these cases. But injecting chloroform inside, and for me, I'm not going to do that.
Okay.
Because I'm not sure about the long-term side effects of this material. Once there is any study confirm this, I will be happy to do it. Because at the end of the day, we want to make things easy for us and for the patient.
Right. I agree with you because this is not scientifically proven what I do every day. And however, as I told you, 98% of my cases are retreatment. And I see in many of the cases I do every day, I see gut aperture outside the root canals. Because I receive only difficult cases as well as broken file removal cases. So almost every single day I use chloroform, and I use it sometimes outside the root canal. It's not rare cases. Actually, I do it almost every day. And
so in the next edition of Pathway of the Bulb, hopefully we will read this.
Yes, I want to do that. Yes.
If we read it, okay, then why not?
Okay. Last question, Professor. I think 1 hour has ended, and
yes,
we have last
please,
question. Yes. How many times you use rotary file or even manual file, K files?
Manual K files?
Oh, rotary files.
Oh, every day, every case. I don't use I don't use hand files like a K files.
We don't use it. Okay, but because, how many times you use it before you throw it?
Oh, how many times? Oh,
yes.
that's
How
a
many
good
cases?
question.
How many
Yes.
cases? How many canals?
If I see any deformation over the files, I will throw it away.
Otherwise, you keep using it.
Yes, or I may fracture the instrument inside the root canal, and which is not a big problem for me. But I use it like until I break it.
Can you allow me not to agree with you again, my friend? I
Yes,
can
yes.
see where you come from.
Yes, but I don't want to. Of course, first of all, just don't get me wrong. I do not want to break the file in the root canal.
Yes,
but
yes.
I always try to avoid any accident, like a fracturing the instrument. But sometimes I do fracture the instrument inside the root canal. Last year, I broke 6 or 7 instruments inside the root canal, and it's a very low rate of fracturing the instrument in my office.
Okay. If you allow me, please, here I don't agree with you, and I'm going to explain why. Of course, not all dentists are Dr. Yoshi. You are able to remove every single fracture instruments, even it's beyond the apex. We have no doubt about that. You are the magic.
Number one.
Okay. But using rotary files, as long as it has no deflection, no distortion, this is what I cannot agree with you, because we all know that rotary files, nickel titanium files, they can be fatigued, they can be failed even with no deformation.
Exactly.
This is one thing.
Cyclic fatigue.
The other thing is, it's not about the deformation, whether it's micro or macro. It's about the quality of cutting dentine. When I'm using a file that many times, that means when I cut dentine for the 5th time, for example, the quality, the efficiency of cutting, and here I'm not talking about the amount, I'm talking about the quality of cutting. I'm sure, or let's say I believe that I'm causing micro cracks. Like if it is, you are going to slot a sheep with a sharp knife, it's completely different when you want to slot the sheep with a blunt knife. So when we use the file, rotary files, many times, even though there is no deflection, there is no distortion, the file, the cutting efficiency of the file is definitely very low, and I'm trying to cut the dentine, the file will get fatigued more, and the dentine will be damaged by creating micro cracks. And we are afraid that these micro cracks might propagate and end up with single root vertical fracture. This is my concern, and that's why I always say single use, and even some cases I use more than one file for the same case. This is my protocol, and this is my point of view. You might not agree with me, but we will let the audience to agree or not.
I 100% agree with you on that point, because I think the instrument is a consumable product, and it should be discarded on every use. So I completely agree with you, and you can stay away from recontamination if you use it only for a single time.
Yes, this
so
is
I completely agree with you.
Thank you, my friend.
Okay.
And in that case, maybe it's time to raise your fees, because the instrument you use is a single use.
Yes.
Okay. Excellent.
Because in some countries, you cannot do that because of the lower fees.
Yes, I do agree with you. Yes.
Okay. Any other question, Prof. Madarati?
No, I think if anybody, any dentist or who's attending this webinar, or later on who is going to watch this webinar, they can ask, and me and Dr. Yoshi are more than happy to answer their question later on.
Okay. Thank you so much, Professor Yoshi. we would like to thank you so much for this
Thank you
great
very much.
event.
Thank you
for your
a
time.
lot, dear friend Dr. Yoshi, for your valuable time. I really enjoyed it. Thank you, Dr.
I
Abu Baida.
also really enjoyed talking with you, and
Yes,
it's my
we need to
honor
mention
and
that,
also
that
pleasure.
I've known Dr. Yoshi for since 2007, but
Yes,
we
yes,
have
yes.
not met yet in real
Yes.
life, and this is the first time or the second time that we meet virtually. So hopefully I will meet with him, with you, my friend, very soon, inshallah.
Yes, yes. I like to meet you in person very soon.
Me too. I'm very eager to meet you, my friend.
Me too. Thank you very much for your time, and I really enjoy talking and discussion and covering many topics.
Yes, thanks a lot, and thanks for the attendees. I think we can finish this session.
Okay, thank you so much again, Prof. Yoshi.
Thank you very much. Have a good evening.
It's our honor, our pleasure. Okay.
Goodbye.
Have a good day. Bye.